Hello everyone, I am Ritu Adhikari, a student of Banarsidas Chandiwala Institute of Physiotherapy. Today I am here with the topic Special Test of Elbow Injuries. The main bones of the arm are the humerus of the upper arm, the radius and the ulna of the lower arm. The lateral and the medial epicondyles are the parts of the humerus. Elbow joint is the synovial hinge joint and is one of the most commonly dislocated joints in the body. Elbow injuries can be minor or serious and may include symptoms like pain, numbness, tingling sensation, swelling, weakness or decreased range of motion. Elbow injuries occur most commonly during sports or recreational activities, work-related tasks, work around the home and falls. So, to examine the elbow injuries, we perform some specific special tests. These special tests are a part of orthopedic assessment. So, the very first test that we are going to perform today is the instabilities of the elbow joint. The instabilities of the elbow joint comprises the valgus and varus instabilities. Let's move on. The valgus instability. This is to test the medial collateral ligament. In this, the patient's arm is stabilized with one of the examiner's hand at the elbow and the other hand is placed above the patient's wrist. Now, an abduction or valgus force is applied at the distal forearm while the MCL is palpated. It has been recommended to place the arm in a fully laterally rotated position. The laxity, decreased mobility or altered pain is compared with the uninvolved elbow. Now comes the varus instability. This is to test the lateral collateral ligament. In this, the patient's arm is slightly flexed between 20 to 30 degrees and is stabilized with one of the examiner's hand medially at the elbow joint while the other hand is placed above the patient's wrist. The examiner then applies an adduction or varus force to the distal forearm while the lateral collateral ligament is palpated. The examiner feels the ligament tense when the test is applied. Laxity, decreased mobility or pain is compared with the uninvolved elbow. Increased laxity or soft end feel is indicative of primary, secondary or tertiary sprain. Test for biceps tendon rupture. To conduct the test, the patient will be in sitting position and the therapist gonna stand next to the affected arm. With the forearm resting on the thighs, the elbow is flexed 60 to 80 degrees to minimize tension in the brachialis and to isolate the biceps to forearm supination. It is proceeded by slightly pronating the forearm to place the tension on the biceps tendon. The examiner then squeezes or grasps the biceps muscle belly. The test is considered positive for biceps tendon rupture if forearm supination cannot be observed. Test for epicondylitis. The lateral epicondylitis, better known as tennis elbow. The chronic overuse injury to the extensor tendons may result in lateral epicondylitis. The most commonly involved structure is the extensor carpi radialis brevis tendon. Repeated microtrauma to the tendon leads to disruption and degeneration of tendon's internal structure. The first test for lateral epicondylitis is the cosines test. With one hand, the examiner's thumb rests on the patient's lateral epicondyle while stabilizing the patient's elbow. Patient is then asked to actively make a fist, pronate the forearm and radially deviate and extend the wrist, after which the examiner resists the motion. The test is considered positive when the patient complains of a sudden severe pain in the area of lateral epicondyle. The other test for the lateral epicondylitis is the Mills test. The patient is in standing position while the therapist palpates the lateral epicondyle. Then passively pronate the patient's forearm, flex the wrist and extend the elbow fully. The test is considered positive if patient complains about the sudden pain at the lateral epicondyle. This maneuver also puts stress on the radial nerve and in the presence of compression of radial nerve causes symptoms similar to those of the tennis elbow. Electrodiagnostic studies helps to differentiate the two conditions. Medial epicondylitis, better known as golfer's elbow. The site of pain is on the inside of the elbow. To perform this test, the patient is in standing position. The therapist fixes the patient's humerus and palpates the medial epicondyle and passively supinate the patient's forearm, extend the wrist and then extend the elbow fully. The test is positive when patient complains sudden pain at the medial epicondyle. Test for neurological dysfunction. The first is the elbow flexion test. It is performed for cubital tunnel syndrome. This test is conducted with the patient in standing or sitting position. The patient is asked to fully flex the elbow, forearms maximally supinated, and the wrist is placed into extension. This position is maintained for up to 3 to 5 minutes. Test is positive in case of reproduction of pain, numbness or tingling sensation along the ulnar nerve distribution during the 3 to 5 minutes. The another test for the neurological dysfunction is the Tenel sign. It is for the cubital tunnel syndrome. To conduct the test, the patient is in sitting position. Support the arm to be tested and then using a reflex hammer, lightly tap on the ulnar nerve just proximal to the cubital tunnel for 4 to 6 times. The test is positive when the patient complains of pain, numbness or tingling sensation over the ulnar nerve distribution. Now I am done with the special test of elbow injuries, so I will finish up by saying thank you for your attention.